My name is Brian Clark from the Ohio Musculoskeletal and Neurological Institute at Ohio University. And today I'm going to talk to you about most recent work looking at neuromuscular junction transmission failure and sarcopenia and its association with muscle quality. Before I begin, I should note a variety of conflicts, namely that NMD Pharma funded the work that is being presented by myself here today. So I want to pick up where Dr. Arnold left off. Remember, he just presented data showing that we've done a number of preclinical rodent studies showing that advancing age is associated with increases in neuromuscular or NMJ transmission failure, and that is mapping to impairments in motor or muscle function. So in this particular study, we decided to extend that preclinical work to a clinical cohort of older adults with sarcopenia to determine both the magnitude or extent of NMJ transmission failure in this patient population, as well as whether or not NMJ transmission failure is associated with reductions in muscle quality. Here I'm operationally defining muscle quality as the voluntary strength normalized to muscle size. And we used the stimulated single fiber EMG technique that Dr. Arnold described to directly assay NMJ transmission. So just a quick overview of the study design and methods. We had 8 healthy young and middle-aged adults. The mean age was around 30 years, of which about 38% were female. And we had 10 older adults, mean age was 86, the range was 82 to 97, around 40% women. And we selectively or specifically targeted recruitment of older adults in their 80s and 90s who self-reported notable physical limitations in function and mobility. We assessed their isokinetic leg extension strength of their non-dominant leg extensor muscles at 60 degrees per second on a Biodex dynamometer. And we also obtained MRIs of their non-dominant quadriceps muscles, which we then used to subsequently calculate quadriceps muscle volume after subtracting out fat. And then, as I noted before, we used stimulated single fiber EMG to quantify both jitter, or the time locking, or degree of variability in time locking, as well as blocking, or the inability to transmit the synaptic signal, using a selective electrode that was placed into the muscle, and then 2 stimulating electrodes that were around the nerve twig. The key study participant characteristics are that 9 of our 10 older adults exhibited clinically meaningful leg extensor weakness. In fact, 7 of these were in a high-risk group and 2 in a moderate-risk group based on cut points that were put forth around 15 years ago from a Health ABC longitudinal study that are predictive of the development of severe mobility limitations. Specifically, this is an isokinetic leg extension strength to body weight ratio. 7 of these 10 individuals also exhibited hand grip weakness based on the most recent European working group definition. And 50% of these individuals had SPPB scores at less than or equal to 8. So henceforth in the data, I'm going to present data on what we're defining 9 weak older adults. Again, this is based on the leg extensor weakness thresholds. I'll commonly present the 1 older adult case that did not have weakness, and then we'll show the adult controls. But if I can just point out a few things, our weak older adults on average were around 86 years of age. They were of similar height, weight, and BMI as our controls. They had notably lower muscle strength for both leg extensors and hand grip, as one would expect. They had notably smaller muscle mass, as well as assessed both via MRI as well as dual energy X-ray absorptiometry. And they had substantially more fat, and they had notable reductions in physical function. So our key findings were that our weak older adult cases exhibited high degrees of quadriceps jitter, the time locking of the action potentials, as well as high levels of blocking, or the complete abolition of an action potential. And I want to point out that these absolute values are very strikingly similar to what we have seen in our rodent studies. with around 13 to 14% of the action potentials being completely blocked in our weak older adult cases, and jitter on the range of around 25 to 30 microseconds. If we look at the association of these indices of transmission failure, muscle quality, the first thing I want to point out is that indeed our weak older adult cases had a lower strength normalized to mass value, around 40% lower than our adult controls, and that we observed moderate to moderately strong associations between jitter and blocking versus muscle quality, with values ranging between around 0.5 to 0.7. So in conclusion, data from this experiment provides strong, direct, and novel evidence for NMJ transmission failure in sarcopenic older adults in a clinically relevant muscle group of the quadriceps. And the degree of transmission failure was associated with impairments in muscle function. And these findings, in our opinion, suggest that enhancing NMJ transmission is a viable therapeutic target for increasing muscle function in older adults. And at this time, I will turn it over to Thomas Holm Peterson from NMD Pharma to present some further work.